Hello, welcome to the Center for Connected Health Policy, Telehealth and Medicaid, a Policy webinar series, Winter Edition. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. Today's topic will be about patient engagement and education during the public health emergency. A few disclaimers and friendly reminders for today. Please note that any information provided in today's talk should not be considered legal advice. It is strictly for informational purposes. If you wish to have a formal legal opinion, please consult with your legal counsel. Also know if a piece of equipment or a company is mentioned today, CCHP has no financial interest or arrangement or relationship with such a company. Today's webinar will be recorded and the slides will be available after the webinar, approximately about 48 hours afterwards. We ask that during the session, people refrain from making any type of political statements or advertising during the webinars during the Q&A section. A little bit of background about CCHP. We were established in 2009 as a California telehealth policy organization underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Resource Center became available through a grant from HRSA in 2012. CCHP applied for that, we got that, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners. CCHP is one of 14 telehealth resource centers who are underneath the same grant program. There are 12 regional resource centers that cover specific states and 2 national centers, one that covers policy, which is CCHP, and another one that covers technology. However, all 14 telehealth resource centers work collaboratively together underneath the umbrella of the National Consortium of Telehealth Resource Centers. I encourage you, if you have questions regarding telehealth, whether it's on policy, workflow, program operations, or technology, to please reach out to your telehealth resource center. But know if you reach out to one, you're really getting all 14 of us, so you really will not fail to reach somebody who knows an answer, because they will refer any type of question that they won't be able to answer to their colleagues at the other telehealth resource centers. I would just like to take a moment to thank the CCHP team for helping put the series together, especially a special thank you to Samuel Taylor, who spearheaded this particular project. As I said, today's webinar will be looking at patient education and engagement. Our future webinar is going to be on what's next, a roadmap for Medicaid telehealth policy beyond the pandemic, and it will take place on February 5th. CCHP decided to put this series together because of the interesting things that Medicaid programs were doing around telehealth policy. We considered this an opportunity for Medicaid programs to learn from each other and for the general public to also hear some of the innovative actions that Medicaid programs have taken during the pandemic in regards to telehealth. Please know that there is also a Twitter hashtag that you can use during the session, and we hope that you will join us in tweeting out information as we listen to our speakers. And without further ado, I will hand it over to Samuel Taylor, who will be moderating today's webinar.
Thanks, May. Again, my name is Samuel Taylor, and it's my privilege and honor to introduce the agenda for today and our lovely speakers who are representing a number of different states. We try to get a lot of geographic and Medicaid diversity for our policy representation today. So first presentation, we'll be hearing from Mainecare, which is Maine's Medicaid program in the Department of Health and Human Services. We'll be hearing from Maine's Medicaid Director, Michelle Probert, as well as the Director of Communications for Mainecare, Sarah Grant. Following that, we'll be hearing from Traylor Rains, who's the Deputy State Medicaid Director for Oklahoma's Medicaid program within the Oklahoma Healthcare Authority. And then last but not least, we'll be hearing from Dr. Chetan Bacciareddy, who is the Chief Medical Officer for Virginia's Medicaid program, which is housed within the Virginia Department of Medical Assistance Services. Next slide. And without further ado, I'd love to hand it over and introduce our first 2 speakers. We're having a tag team from the lovely Maine team this morning. First up will be Michelle Probert. She's been the Director of Mainecare, which is Maine's Medicaid program, since early 2019. Mainecare currently provides healthcare coverage to over 320,000 Mainers, including 62,000 to date who have benefited from Mainecare's expansion under the Affordable Care Act. Michelle now leads the department in her efforts to take Mainecare to the next level, with a goal of more than doubling Mainecare spending associated with alternative payment models from almost 20% to 40% by 2023. In response to COVID, Mainecare has expanded coverage of testing and related services to individuals who are uninsured, as well as undocumented non-citizens, and achieved a 900% increase in telehealth utilization. And they'll talk a little bit more about that. She previously served with Mainecare from 2011 to 2014, She has a master's degree in public policy from the University of California at Berkeley and grew up in Maine and now resides in Brunswick with her husband and 2 children. Immediately following Michelle, we'll be hearing from the Director of Communications for Mainecare. In this role, Sarah Grant has provided strategic direction on communication efforts associated with large-scale federal and state initiatives that impact Mainecare members and the provider network. She's directed and overseen the implementation of communication plans related to the implementation of new Medicaid management information system, the transition to ICD-10 billing codes, and CMS's provider re-enrollment and revalidation requirements. She has overseen communication and stakeholder engagement efforts associated with Mainecare's response to COVID-19 public health emergency, which you'll be hearing about today. As a lifelong Maine resident, she holds a bachelor's degree in English from the University of Maine and a certificate of graduate study in nonprofit management from the Muskie School of Public Service at the University of Southern Maine. She lives in Farmingdale with her husband and 4 children. Without further ado, I'm pleased to throw it over to Maine. Take it away.
Great, thank you very much, Samuel, for that very generous introduction. First thing I notice, of course, is with the sunshine today, I'm missing one of those Zoom's no-nos about making sure that the light that is surrounding you looks normal, and this clearly doesn't. So hopefully it's not too distracting for folks. I'm very honored to get asked to be here today and excited to share the great work of Maine's Medicaid program with telehealth during this pandemic. So the good news for us to start with, and for the members that we serve, is that we had a very robust and progressive telehealth policy in place at the beginning of the pandemic. We had this policy in place since 2016. And so we were a bit ahead of the game in terms of making sure that we had payment parity, that we could have our members receiving telehealth in the home and have payment available for that. We have for years looked at telehealth as a mode of service delivery versus a service itself. And so we really have approached telehealth as that mode, and our underlying policy is the same for the most part, and you just need to indicate that the service is provided by telehealth, and then you get paid the same way. We have also historically offered some flexibility with having audio-only services when a more interactive mode of delivery, I'm struggling on that word today, is not available. So that was already in place. And like many others, we did move quickly when the pandemic hit in order to take advantage of further flexibility. We had actually, again, luckily already had actions in place to expand our telehealth to be able to provide coverage for pharmacy as well, including substance use disorder services. So that was new, and we were able to turn that on pretty quickly. Also taking advantage of a lot of the new as well as existing evaluation and management codes that really helped our providers to do a lot of the triage and assessment work that was especially important when access to in-person care was really limited. And then lastly, we had a bit more of a challenge in the state around teledental, because our Board of Dental hasn't approved an expanded scope, but we were able to at least enable that kind of triage and screening to take place via teledental. So given that we were in pretty good shape with our policy, it felt like the first number of weeks of the pandemic were really a lot of communications related activities for our team. So we immediately jumped in, both from our broad communications to providers, as well as member-focused communications and our provider relations team, to get a lot of detailed guidance out there and available. Because while we had that strong underlying policy, and you'll see this in the charts that are coming up, nobody was using it. And so there was still a huge learning curve, even though we were on solid footing in terms of what we were able to do. So to jump into some of the data. So this is our chart. As I said, hardly anybody was utilizing telehealth, and you can tell that on the left side of this graph here. We were averaging about 1,000 units that were billed per week up until the beginning of the pandemic. And at our height, we peaked out at about 90,000 per week. And so that is where the 900% jump comes from. In addition to the evaluation and management services that I mentioned, we were also, I think, amongst the first in the country to proactively say, hey, yes, we want you to provide well child visits via telehealth as well, even though there's recognition that you need to make sure that you have in-person follow-up for vaccinations, et cetera. So you can see that since that peak, which happened in about May, we have seen a gradual decline in telehealth services since then. I was happy to, in part happy to see that those telehealth services have leveled out, but as we know, part of the reason why we're seeing increased use again is because of the surge in the pandemic. And you can see at the end, there's two different colored lines there, and that's just to indicate the gray line is what we expect the level to be at once we've seen more claims completion, and the blue is what has come in so far. And so this is a chart just showing the percentage of members who have had a telehealth claim. And this is based off all enrolled Mainecare members, regardless of whether or not they've received any healthcare services. And so that puts that 12% in perspective. So again, at the peak, which in this case was around April, for the month of April, looking at all 320,000 or so of Mainecare's members, 12% of those had used telehealth, which is a pretty significant amount of the population. And since then, we've seen that level out at around 7%. It looks like maybe there's a little bit of an increase towards the end. This chart only shows us through November. So we'll see how that looks in the following months when the surge hit. So this is my opportunity to brag a little bit, because we were really thrilled when CMS put out a data book looking at telehealth utilization around the country. And this slide looks at telehealth use specifically amongst children in the Medicaid population. And the dark color here means that there's a higher proportion of use. And as you can see, Maine is one of the top 2 states in the whole country in terms of our success at children's telehealth utilization, which we're really proud of. There was a similar chart we didn't include that was for telehealth use amongst adults under age 65. And we were in about the top 5 states when this analysis was conducted. The area where we didn't do quite so well, and this relates to the next slide, is looking at our older adults in the state of Maine. And so we have had a more difficult time reaching this population. You can see here this, it's a similar chart looking at the percentage of Mainecare members each month who have used telehealth. And so our adults had the highest rate of utilization, peaking at over 14%. Kids peaked at about 13%, but then our older adults are way lower than that. They're about 1/6 as likely as other members to use telehealth. So this slide looks confusing when you first look at it, but I think it's important to show because it's a very compelling slide that shows just what an incredibly critical service telehealth was in order to maintain needed services to our member population. And so medication management services, this is often psychiatric medication management. It also, I believe, includes some Suboxone medication management. But that medication management, as well as the accompanying drugs that these members rely on, are so important. And what you're looking at here is, if you look at the orange dashed line, that is what happened to in-person care once the pandemic hit. And you can see that it really nosedived, and that after a gradual increase with the surge of the pandemic, we've seen it really drop again. The good news is that the top line is the actual service utilization that continued with telehealth. And so for the most part, the service has really remained intact and has remained stable over the time period. The drops, or the bigger valleys that you see on the right are really associated with Thanksgiving and with Christmas. And so that is a typical pattern we see in the claims. But all in all, medication management has been able to continue to reach the members who depend on that service. All right, so we've also done some analysis to see whether we see different usage of telehealth amongst our different diverse populations in the state of Maine. I already showed you looking at a filter of age, and this looks at a filter of race. And if you're not aware, Maine is not at all a racially diverse state, but we certainly do have significant populations, especially in a couple of our more urban areas, and we have a lot of what we refer to as new Mainer populations, which are a lot of asylum seekers from various countries, but with a higher concentration of a number of African countries. So this was interesting to us because you can see that the two groups that showed the highest rates of telehealth use are individuals who've indicated that they identify with two or more races, which is the top turquoise line, and then followed by white individuals, which is in the orange. And so that might not have been what, for example, my prediction might have been initially. And I will also state the caveat that we know that in the state of Maine, especially, our communities of color and our BIPOC communities tend to be younger than the rest of the state of Maine's population. And so age is definitely a factor that plays into the differing percentages that you see here as well. Also looking at language use, so members with English as their primary language are over 50% more likely to use telehealth. This was not surprising to me, but certainly indicates a barrier that we need to get better at overcoming. And I didn't include a slide on this, but I found it really interesting, so I'll mention it. So I showed that our older Mainers have really had the lowest rates of telehealth use. But when we look at those older Mainers over age 65, the subpopulation that has been most successful at using telehealth are our Black African American populations. By far, and I was presenting to a civil rights webinar on this topic, and a community leader was part of that presentation, and she said, "Oh, well, that makes complete sense because we know that a lot of our new Mainer families are living in multi-generational families, and so the younger family members do a great job of helping their older family members get on telehealth," and you can see that really clearly in the data. All right, so I am happy to turn things over to my colleague, Sarah Grant, and then we can both take questions together. Thank you.
Thanks, Michelle. So as the Director of Communications for Mainecare, I had the task of making our members aware of telehealth as an option during the COVID-19 pandemic. As we said, we had a robust policy, providers weren't necessarily using it, and our members were certainly not as aware of it as we probably wanted them to be. So the first goal was just to bring awareness to telehealth as an option for members, to make them comfortable with it as an option and the security of it, and that the quality of services would still be as good as they could be when delivered in person. We specifically were focusing on ensuring that people who needed mental health or SUD services were able to continue accessing and not lose continuous care, as well as focusing on children and making sure that they did not miss their developmental screenings or other important appointments. We also wanted to make sure to highlight that telehealth at this time could be used just audio only. You didn't need to have laptop or internet connection in order to have a telehealth appointment. So those were kind of our three big points that we were trying to reach with our member population. So the first thing that we did was we put together a designated website that's specific to the telehealth services. It provided some FAQs, just really focusing on plain language, explaining what telehealth is, how it works, the types of appointments you can get, answered some questions that we knew people had around security concerns or data usage, or how this would affect minutes on their cell phones. So we tried to create this as a one-stop shop for any kinds of questions that people may have had about telehealth, and future communications that we put out there just kind of drove everyone to this website to kind of educate them on how to ask their providers for whether or not their services can be delivered using telehealth. So following that, once we had our website up, the first thing we did was send a mailer to 177,000 of our members. So at that time, we actually did not have the ability to send direct emails. So this was our primary mode of communication, but we also wanted to make sure that we did reach everybody. And so mail is one way to do that. So again, this kind of mirrored what we had on our website, just the high level points that we wanted to make, keeping it really simple, just directing people to our website and encouraging them to consider telehealth. And we were able to leverage some of our funding to have some paid outreach components. So we did work with a marketing firm to create a bunch of online display ads, banner ads. We had some Instagram stories and Facebook advertising. So we really tried to be across all platforms online, whether it was Google search, just direct advertising to people in the demographics that we were trying to target. And those are just some examples of some of our ads. Oh, that was fast. So this is our one of our videos. So I think probably the most exciting piece was being able to create some videos that were for TV, digital, YouTube. We did one longer telehealth overall kind of general ad that featured a few familiar faces in the Mainecare and the Maine medical community, trying to give a feel for what people would relate to, something that looked like their homes, and just making it seem more accessible. So we had a longer one, and then we had a few 30-second, 15-second ones. And some of the 30-second ones were focused on children's health or behavioral health services. This one here, I just wanted to share as an example. It's one of our shorter 15-second ones that was really just kind of like a broad awareness to highlight for you. I would be happy to share any others after this if people are interested in seeing some of the longer ones. I'll just let that play.
From physical therapy to mental health needs to regular checkups, with a telehealth visit, you get the care you need from the comfort of your home. Call your provider today to see if a telehealth visit can work for you. Learn more at maine.gov/DHHS/telehealth. From physical.
All right. Thanks to Sarah and to Michelle for a great first presentation and way to open up with some great media. We're going to now ask our main speakers to come back on off mute, and we're going to open the floor for some Q&A. Just a quick reminder to our audience members, please use the Q&A function to submit questions. Unfortunately, we won't be able to get to every question. However, if we do flag your question for follow-up, we will make sure that the panel-wide Q&A, so all of our panelists will be coming back online for a panel-wide Q&A at the end. We'll try to make sure that all the questions do get addressed that are relevant and appropriate. So our first question was actually, there's a lot of ubiquity around this question. So a lot of people submitted some questions around this, and we wanted to maybe just follow up. Have you done anything around ensuring that folks in rural areas, in particular older adults or those who may be impacted by the digital divide, have access to broadband? Not just necessarily doing some outreach and communications around the new benefits, telehealth expansions, but around broadband access.
So as the state's Medicaid agency, our ability to do that has been limited. We've certainly had conversations with our colleagues at the Office of Behavioral Health, and we focused on trying to get resources out there that providers may be able to take advantage of, and also looking at the programs that are available to, for example, get lower income individuals access to phones that they might be able to use for telehealth access. Beyond that, this isn't the broadband side of things, but it certainly is a piece of the equation of getting services out to more rural areas. We have a grant under the Support Act from CMS, where we're working specifically with substance use disorder providers, and we've focused resources from that grant on making sure that those more rural providers especially do have the tools and technology able to serve their populations. Sarah, did I miss anything that you would add?
No, I think just focusing also on the audio only component is really a good point. Just for people who don't have internet or broadband access, the ability to access telehealth other ways is also helpful.
Great. And our next question is about some of those trends that you saw in telehealth utilization. You talked a little bit about the rural-urban divide, and that the state is a primarily rural state. Have you been able to dig into the data and look to see if the increase in utilization has been driven primarily by your rural beneficiaries, or is there also some increase in your urban areas, maybe around Portland, Maine?
Sure. So I partially answered this in the chat. We have a slide on it that I'm regretting not having put in there, but you see the exact same pattern in our urban, rural, and we also looked at a definition of super rural parts of the state. So every place is showing that spike and then drop off and leveling off. I was happy to see that there actually was not much of a divide between the urban and the rural. Those trends were pretty close together. It was really when we got to the super rural where you saw a disparity in access to telehealth.
Interesting. Do you have any sense of whether are you using as your performance metric for telehealth utilization and the outreach campaign, are you using telehealth utilization primarily, or have you looked at maybe some other performance measures like website traffic to see if there's a direct connection between some of the digital or other media campaigns that you did around telehealth?
Yeah, we have, just as far as the website goes, I mean, the page was a new page, so it was hard to measure whether or not it had increased traffic from prior to the outreach campaign. But I think on the website slide, just since June, the website has had 22,000 page views, 15,000 of them being unique, and the FAQ has been downloaded 114 times. We can tell that the website traffic is coming from a direct link by far, and then Google and Facebook follow, far behind that. So that's kind of what we have for website traffic data at this time. We have not, or I have not, done an analysis of our telehealth utilization bumped up against when we had advertisings running, partly because that was a little bit after the peak of our telehealth utilization, and it was a very short campaign. We ran it for, I think, about 3 to 4 weeks was all that we were able to run it for. Michelle, you probably have more data to share.
I think you've got it, Sarah.
We have time for about 2 more questions with our Maine folks. The first one I want to ask you is was there any evidence based when Maine was considering sort of the shift or expansion? Did Maine rely on some of the evidence-based practices, or perhaps look to other states for learning or best practices in expanding their telehealth coverages?
It's funny, I might get myself in trouble by saying this with this crowd, but I think because across the country, there hasn't been great use of telehealth prior to the pandemic. It didn't really feel like there were evidence-based practices in terms of what is actually working that well. So, we know that payment parity is a big piece of that, and we had already had that as an important component of our telehealth practice. I think the fact that we had some flexibility with audio only was helpful, and obviously the feds providing additional flexibility around that was important also. You know, I feel like there's still outstanding questions as to what the evidence base is showing in terms of the question comes up of, you know, is telehealth appropriate for every service? We had a general requirement as part of our policy that you need to have a comparable quality for telehealth services as compared to the same service provided in person. We actually implemented a selective waiver of that requirement during the pandemic, because even if there is broad recognition that it's better to have a service in person, if the alternative is not having the service at all, then we obviously would prefer the service to be provided via telehealth. So we did, you know, we put in place that waiver, but I've heard the question asked of like, are there services that really just don't work well in telehealth that maybe shouldn't be allowed? There's also the question of, we know that audio only is really fantastic for access, but do we know at this point, and maybe here somebody has an answer, but do we know whether or not you get the comparable quality if it is audio only and you don't have that that visual piece, especially for mental health, for example. And so I think that there's a lot of questions we don't know the answer to, and we're hoping that now that we've got a really great data set with COVID, that some of those answers will start to emerge.
Great, and we have time for just one more question. This would be a fairly painless question. Have you seen any, did your policy, when you were addressing maybe what expansions need to happen, did you address any questions around asynchronous texting? Was there any decision to increase that, and does your temporary policy currently provide for that?
So it's funny you said that that's the painless question, because that's the question that gets enough into the weeds that I don't actually know the answer. I do not recall asynchronous texting come up as part of our policy, but that's something that I'll have to follow up on.
All right, great. Well, thank you again to our speakers from Maine. We're going to transition now over to our second presentation, which is Traylor Rains from the Oklahoma Healthcare Authority. It's my privilege to introduce everybody to Traylor. Traylor currently serves as the Deputy State Medicaid Director at the Oklahoma Healthcare Authority. After earning his law degree from Baylor University, he began his now 15-year career in public service with the state of Oklahoma, and has included leadership roles within the Department of Mental Health and Substance Abuse Services and the Department of Human Services. In his current role, Traylor is responsible for directing several divisions within OHCA, including behavioral health, federal and state authorities, long-term services and supports, and tribal government relations. He has led the planning and implementation efforts for several state health service initiatives, including Oklahoma's Health Homes for Adults with Serious Mental Illness and Serious Emotional Disturbance, the Certified Community Behavioral Health Clinic Model, and Oklahoma's Medicaid expansion. He serves on the State Board of Behavioral Health Licensure, the Public Health Institute of Oklahoma, the Oklahoma Autism Center Foundation Strategic Planning Committee, and the State Behavioral Health Advisory Council. At this time, I'm pleased to turn it over to Traylor.
Hi, thanks, Samuel. It's my privilege to be able to join you all today and kind of give a high-level overview of the response that Oklahoma has had. Kind of hate following Maine. They had such a great presentation, and I'm really impressed about, especially the outreach campaigns, and kind of seeing some things that maybe we could have done a little better. But I think we're all just, we're doing the best we can during the COVID response. So I bring in a little, I think on my first slide, just kind of letting you know about our initial response. The public health emergency was announced, and that evening we started working with our MMIS vendor to go ahead and open up the codes for reimbursement for most, not all, but most of our services. Like Maine, we have had a fairly robust telehealth program as a service delivery since about 2009. Over the years, we've lessened some of the restrictions that we've had around on it. So in the last 5 years, it's fairly well utilized, especially in our behavioral health provider community. But there was a lot of medical codes, as well as the phone access codes and like dental codes that weren't typically open for telehealth. So we explored those, worked with our medical division to open those. We did seek, I believe at some point later after we sought our 1135 authority, CMS did do blanket waivers for a lot of this, but you know, we ran into things like telehealth or telephonic services for our tribal providers, and our FQHCs weren't allowed federally. So we needed to seek an emergency approval through an 1135 for some of those requirements. But most of our telehealth flexibilities are at the state's discretion. So this will give you an overview of, we pulled a snip of data from March to October of 2020 and compared that same time frame to 2019 utilization. So you'll notice we had a dramatic increase in the utilization of telehealth during the pandemic. So as far as total members, in 2019, we had, you know, 10,500 or so members access services through telehealth. That number went up to 167,000 in 2020, which is over a 1,500% increase, which was just amazing. That our providers were able to get everything in line so quickly to get the platforms up and going, and that our members had a comfort level with it. As far as claims volume, the 2019 period was around 24,000. That went up to 977,000, almost a 4,000% increase. Total reimbursement went up over 3,000%, from 1.9 million to 66 million. An average claims per member of 5.9 in 2020 as compared to 2.3 back in 2019. Active providers utilizing telemedicine, I thought this was interesting, was just under 600 in 2019 and up to over 10,000 in 2020 that are utilizing it. We know that a lot of this is due in part to the flexibilities that HIPAA has been waived, or the enforcement of HIPAA has been waived as it relates to telemedicine platforms. And so you don't have to invest in a HIPAA compliant platform, which has often been the obstacle for a lot of our providers and members. So utilizing things such as FaceTime on your phone or other, Skype that are not protected has been allowed during the PHE. So that's really enabled a quick expansion and rollout of telehealth. So when we drill down to see what our top 10 procedure codes use, really no surprise to us in Oklahoma. Again, our behavioral health providers have utilized telehealth for kind of a little longer than our medical providers. So our number one was psychotherapy. 2019, we had about 9,500 individuals access that through telehealth, and that went to 500, almost 500,000 in 2020. Second, no surprise, an E&M code, a physician visit, went from about 66,000 a year to 87,000. Kind of backing up, you have to back up a slide, but I wanted to mention, as far as our rollout and getting our providers comfortable with utilizing it, as soon as we opened all these codes, me and our Medicaid director, Melanie Anthony, we held about 3 webinars daily for 2 weeks. We had individual webinars set up with every one of our contracted provider types and brought the expertise internally on, explaining how to use telehealth, what codes were open, what the reimbursement was, especially given, this was a lot of their first time to use it. And we've made a lot of changes over the year we don't require someone to present the member for telehealth anymore. We don't reimburse for originating sites. So individuals that may have done telehealth back in, 2009, 2010, it's changed a lot. So we really wanted to get our providers at a certain comfort level on how to use it. And so we provided those webinars as educational opportunities for them. We had great attendance with all of those. Again, time consuming, but it was very worth it. And I think we see that in the numbers. All right, go next slide. So we're focused a lot now on what's next. And so we are doing a lot in order to kind of understand, kind of relating to what Maine was saying about the question around evidence-based practices, there really aren't a lot. All we can really do is evaluate the way it's working currently. We're doing provider and member satisfaction surveys, as soon as we opened up all the telehealth, and really in response to all of our pandemic response and how we've handled it, we've continued to send surveys to our provider and member community to see their comfort level with a lot of the new things that we've rolled out. During COVID, we saw members say about 20% survey noticed a delay in care, but not that they didn't get it, just that it was delayed. But we had 70% surveyed said that they were interested in receiving care through telehealth. I really feel that in the middle of this difficult time really lied a lot of opportunity to get our providers comfortable with use of telehealth, as well as our members. It's funny to me, my colleagues, the ones that have been more historically against the widespread use of telehealth, are surprised that physicians and clients prefer it. And it's funny because I don't know why we're surprised. I mean, I'm enjoying being on this panel from the comfort of my home. The same as if I have a therapist visit or a doctor's visit. There's a comfort of being in your own home and your surroundings, and we're really able to meet people where they are and not require them to come to us to receive their services. So we're continually monitoring through those mechanisms, as well as monitoring utilization. I know there's two different schools of thought, especially within our agency, is high utilization is sometimes seen as a bad thing, or it's getting out of hand, where I see a high utilization as being a good thing. We're getting access out there. In regard to access, Oklahoma is a very rural in areas, a frontier state where we don't have access to a lot of broadband. So like Maine, that's why we open the telephonic codes, hoping to really reach the populations that don't have access or aren't comfortable with accessing it. We've also seen that it's in my conversations with providers, as well as the data, we've noticed that the aging population is not accessing the telehealth opportunities that are afforded to them. So we've been really struggling with outreach to our providers, working with them, trying to really get more penetration into that area of our population, and working with our long-term care folks. That's another thing. We haven't been able to get into the nursing homes to do a lot of assessments. So we have figured out ways for staff to use telehealth platforms in order to better reach those individuals. Now, luckily, Oklahoma's, specifically related to behavioral health, we were one of the original states to get the Certified Community Behavioral Health Clinic demonstration grant. And so through the evolution of that demonstration project, most of our CCBHCs have invested in telehealth technology, including member iPads, especially in the northeast part of Oklahoma through Grand Lake Mental Health Center, specifically. Northeast Oklahoma can be very rural and frontier. And so they have started a project where if you come in for services to Grand Lake Mental Health, and if you've had a crisis episode, or if you've discharged from inpatient care, you automatically get a member iPad. The iPad's locked down. It does have location services enabled, and it is very, all you can do on it is access your therapist or access a case manager. You can't download any apps or anything like that. So, and it comes with its own cell plan, so you don't have to rely on your own Wi-Fi or internet, or go to a place that does. And so that's really been helpful. And our providers that had kind of already invested in that technology, we're seeing a lot of use, expanded use with them. We've actually been in contact with them, and they've had to actually up the data plans on a lot of them, because they are using a lot more data, because they're accessing more through those devices than they previously had. The next thing we're focused on is really outreach and education about what happens after the public health emergency is over and OIG begins enforcing HIPAA again. So those providers, we have looked at the data, and we looked at those providers that were providing telehealth prior to the pandemic, and then those that really started after, and reaching out to them and saying, if you're using a HIPAA compliant platform, that's great. If you're not, you need to be thinking about what's next, because you won't be able to use FaceTime after the PHE. It's my understanding we've gained a little time, as the new administration has indicated that they plan to extend the PHE through the end of 21, and so not quarter by quarter as we have been doing this past year. So really spending the next year working with them on not recommending platforms, but really just ensuring their readiness for that, and that they'll be ready when the time comes to transition if they're comfortable in moving that direction. We're also, continually evaluating what all will we leave open once the PHE is done. I know, again, in our behavioral health, I think we only had to add a few codes. I think case management being one, and maybe peer recovery support services. I fully expect that we'll keep those open. I think we will continue to have conversations, as Maine mentioned, around the use of telephonic services, and really see the efficacy behind a telephonic service. And if you're really getting a quality service and both provider and member are comfortable continuing in that fashion. A little different on the medical side, of course, we'll want the dental visits to be face-to-face. For speaking for Oklahoma, our medical staff are a little more conservative on what they want to see continue to open up, but we continue to evaluate that, like I said, through the surveys and then the utilization data. And that's all I have, and then unless there's any questions.
Thanks so much, Trailer. Thank you to the Healthcare Authority of Oklahoma for joining us again. At this time, we're going to invite folks from the audience to, again, ask questions. We'll remind everyone to please use the Q&A function instead of the chat function so that we can filter and make sure we target those questions directly to our panelists. I do have a handful of questions for you, Trailer. So the first one I'll just start off with is, how is Oklahoma handling remote patient monitoring, specifically with chronic care management and reimbursement for that?
So we actually, I don't have a lot of details around that, but I know that we just recently added that as a covered benefit within the last year. So I can definitely follow up with utilization trends on that. I don't have that at my fingertips, but I know that we do utilize it.
Awesome. And can you speak a little bit more about some of the work that the Healthcare Authority has done with outreach to tribal members, tribal nations, or governments?
Mm-hmm. Yes, we actually have monthly consultations with our tribal leaders around an array of topics, but this was one of the first ones that we specifically had a webinar for our tribal providers in the list of webinars that I mentioned earlier. So we did meet with them, explain what is allowable through the use of telehealth as far as a reimbursable encounter. We continue to meet with them monthly, and this is a standing agenda item for us as the questions arise. The Chickasaw Nation in Southeast Oklahoma has, kind of been ahead of the curve as far as telehealth goes for years, and so they were well prepared as well as a couple of other tribes in the state.
And we have a question too about the difficulty that you mentioned with nursing homes in telehealth. Can you talk a little bit about assisted living centers? Is there any distinction from the Healthcare Authority's eyes in outreach and making sure that the assisted living centers also have a ramp up and implementation for telehealth?
Sure, we've outreached to all of those provider types, and really the struggle has been a lot on our side with our legal folks because I immediately tried to get into a contract agreement with the company that provides the iPads that I mentioned at Grand Lake Mental Health Center. When you're dealing with new uncharted territory with HIPAA and that, we had, it took a while to get that solution. But we finally gotten to where the nursing homes are reaching out to us and saying, we have the technology, we can link with you. And so we've slowly started that process. And that includes assisted living centers. Yes, but especially around we have a money follows the person grant, which requires us to assess individuals in nursing homes to see if they can be served in the community. Sadly, we haven't been able to transition anyone since March because of our inability to do effective assessments. We've recently found a solution for that, and we have started assessments within the past 2 months. So.
Okay, great. Do you expect, you talked a little bit about like the HIPAA, once HIPAA is expected to be reinforced for security and privacy, obviously with the platforms that folks are using. Do you also expect that maybe once the public health emergency is rescinded and once those HIPAA requirements are back in place, do you expect that maybe the number of providers in Oklahoma who are using telehealth to decline or to increase, maybe hold steady? What can you say about that?
I would expect a decline in that for sure. I think right now, being able to use your personal device and a member's personal device is one thing, but when you talk about having to invest in the infrastructure, even if the cost seems to be nominal, and then getting the member on the other end to understand how to walk them through that. Just depending on the provider type, if there's any kind of even nominal barrier in that, they won't do it. So that's why we're really trying to start that outreach now with them and get their comfort level around it and say that there are technology opportunities that are not cumbersome and not that costly. It's just getting them in the right direction. But yeah, I totally expect to see some of it drop off for sure.
Yeah, and that was one of the things that we heard last week too, from during the provider engagement and education. And we would invite everyone to visit our webpage to see the recording from last week for maybe some additional ideas on how to address that. But that's an interesting point, because we were hearing that from the other Medicaid directors last week about having the website ready and having weekly webinars or fireside chats with providers to help keep them encouraged to stay on after the public health emergency. So very interesting points. We're gonna have time for one more question for Trailer. And this one is related to out-of-state providers. Is Oklahoma currently allowing providers to enroll Medicaid patients and to see Medicaid patients in the state of Oklahoma? Did you allow that before? Did you change it for the public health emergency? And what is maybe the plan to do after the public health emergency?
So out-of-state providers seeing Sooner Care members in Oklahoma, we have allowed it, but you have to, of course, be licensed in Oklahoma. Now, our administration is really big on keeping Oklahoma dollars in Oklahoma. And so our provider enrollment folks do screen for that when we have a provider enroll with us. And if it shows that they're out of state, we do go through some checks to make sure that there is a need for that provider type, and especially that we cannot meet that need in state. And so we do go through that, but we have allowed that probably for the last 5 to 10 years, especially around like psychiatry or child psychiatry, where we don't have a lot of access, especially, in our panhandle. But, if you are up in Woodward, Oklahoma, which is, not too far from Amarillo, we would allow that up there because it's, the next state is, literally a stone's throw. So.
Interesting. So allowed, but there's obviously a drive to make sure that we're using Oklahoma providers.
Right.
Very good. Well, thanks again to Trailer for those questions and for a great presentation on Oklahoma Healthcare Authority's response. At this time, we're really happy to introduce our third and final presentation, which comes from Dr. Chethan Bacciareddy, who is the Chief Medical Officer with the Virginia Department of Medical Assistance Services, also known as Virginia Medicaid. And they are dedicated to improving the health and well-being of the over 1.7 million low-income Virginians that they serve. In his current role, he's leading efforts related to COVID-19, the opioid crisis, telehealth, maternal child health, and health equity. He's an adjunct senior fellow at the Leonard Davis Institute of Health Economics at the University of Pennsylvania, and also associate clinical professor at Virginia Commonwealth University, where he cares for patients with substance use disorders. Prior to joining Virginia Medicaid, he was a national clinician scholar at the University of Pennsylvania, where his work focused on improving health populations for individuals affected by HIV, substance use disorders, mental illness, and justice involvement, and looked at ways to inject behavioral economics and clinical trial design. He hails from deep East Texas, studied economics and neurobiology at Harvard, attended medical school at Yale, trained in internal medicine at Brigham and Women's Hospital, Harvard Medical School, and completed a master's in health policy research at the University of Pennsylvania. Without any further ado, I'm happy to turn it over to Dr. Bacciareddy.
Thanks so much, Sam. Can you hear me okay?
Yep, we can.
Great, thank you. And thank you, May. Thank you. Really appreciate the opportunity to be here. And I'm really humbled to go after my colleagues in Maine and Oklahoma. And hearing your presentation, I was just recalling the intensity and the amount of work that went into all of those policies and all of those impacts that you all stated. So just a shout out and appreciation for all the work that you have done and continue to do in your respective states. I've certainly learned a lot from you and my other sister Medicaid programs throughout the COVID-19 pandemic. So as Sam mentioned, and thank you for that kind introduction, I'm the Chief Medical Officer at Virginia Medicaid, affectionately known as DMAS, Department of Medical Assistance Services. And today I'm going to be talking about our experience during the COVID-19 pandemic. As Sam mentioned, I had the opportunity to really understand the transformation of telehealth in Virginia during COVID-19, both from a policy perspective and then also from a provider perspective, because on Fridays today, I see patients in primary care and addiction medicine, and so had the opportunity to undergo that transformation as well, and it's certainly been a pretty remarkable experience. Next slide, please. All right, so a couple things just to bring you up to speed a little bit about Virginia and some context and a little bit of recent history. So in Virginia, everything, like everywhere, everything happened really fast with COVID-19. So March 7th, we had our first presumptive case of COVID-19 in Virginia. On March 12th, just 5 days later, our Governor Northam, declared a state of emergency. Literally a week later, March 12th to March 19th, we had released a brand new policy for telehealth. So we just completely upended and really opened up telehealth, really recognizing that, hey, this is an emergency. We didn't have much in the way of a telehealth policy pre-COVID. And so in some ways, we were starting from scratch. And so we opened up a couple of things and implemented a number of policies, some of them listed here. We allowed home as an originating site prior to March 19th, the COVID-19 emergency. This was not possible in Virginia. And so that had limited the expanse of telemedicine, telehealth. We allowed the use of audio-only services in addition to audio-visual modalities for Medicaid covered services, so quite broad. We allowed payment parity for audio-only, audio-visual with in-person visits. And then a little bit later, so that was March 19th. In addition to that, we simplified billing and documentation to expedite the transition. Again, we knew, not just in Medicaid, but then throughout the state, that there wasn't a lot of uptake or experience with telehealth and telemedicine. So we wanted to make sure the transition, particularly during the pandemic, was seamless. So we simplified billing and documentation and gave a little bit of a grace period for our providers to update their systems to be able to appropriately bill for telehealth and telemedicine, as long as they were documenting appropriately in the chart. On May 15th, we took 2 more steps. We allowed for provider-to-provider consultations, including e-consults, and then we allowed for remote patient monitoring for suspected or confirmed COVID-19. So a lot of changes all at once. Was a very steep learning curve, but something that we felt was really important for our members, for our providers, and really for ensuring access to care. And so with that in mind, that quickly, we're talking about quality now and cost and program integrity. But at the time, and certainly now today, equitable access is really paramount important for telehealth policy. And I do want to distinguish that there is a difference, and I've seen it in the really wonderful questions that came out, between telehealth policy during this public health emergency and telehealth policy over the longer term. Next slide, please. So how did we get the word out? And so, like I said, in Virginia Medicaid, our providers, a lot of them had not used telemedicine, telehealth, and I'll show some data in a minute about our utilization. And our members, our 1.7 million members now, were also not used to accessing telemedicine. And so we really put out the word in a number of ways. Like my colleagues in Maine and Oklahoma, we really amped up our engagement with providers. So we were meeting with health systems, with provider associations, multiple times a week, and really around telehealth and helping them, and you're really listening to them, understanding their needs, helping them gain clarification from a technical perspective. But also we learned that because a lot of people were not used to telemedicine, we also created workflows and diagrams to help them figure out, okay, how might you start telehealth in your own clinic? And so we did that on the behavioral health side. And we also communicated frequently and held webinars for those who provided addiction medicine via telehealth and telemedicine. And we did focus quite a bit, particularly on those 2 groups who we thought of as our most vulnerable, those with behavioral health, severe mental illness, and those with substance use disorders. And so held specific webinars, multiple webinars. We're also lucky to get a Support Act grant, and that certainly helped us. We had a team in place that was really had been engaging with our addiction treatment community, and we're willing to help them quickly transform and move to telehealth during the COVID-19 emergency. As you can see here, really there are a couple ways that we reached out. We pursued what I've heard called an omni-channel approach: social media, text message, email, letters. There's a video. It's a couple minutes long, but it includes yours truly, but then also a number of providers in the community who we connected with and thought of as Telehealth Champions. And we really brought them in as well. And so, and made sure that whatever materials we got from them, we're able to share with others. And so that was really, really important. Having that feedback about where we were missing something or where it didn't make sense, and then being able to issue clarification was also really important and something new for us, right? Telehealth was new for us completely. And so just in terms of some metrics, and I'll just, the other two messages you see here, one was specifically for providers. We have a newsletter just for providers. And then the other one was for our members, the one that has a couple more graphics that includes the suite of what we're doing around COVID-19 from, really in maintaining enrollment, eliminating any copays throughout our program, directly outreaching through our managed care organization, care coordinators, and encouraging use of telehealth, allowing 90-day fills of medicines, including buprenorphine and early refills, and also home delivery of medications as well. Another word about how we focused on substance use disorders, and there are many other stories throughout my agency, and I want to say that this was not a one-person effort or two people or even one team. It was multiple people within the Medicaid agency partnering with countless other providers and patient groups to really make sure that this could be as successful as possible. And of course, we're still doing that work. On the substance use side, what we worked closely with our SOTA, our state opioid treatment authority, to really help out our methadone clinics as well. And so they were concerned from a financial perspective, what do we do? Can we leverage telemedicine? And so we made sure that we were able to reimburse them appropriately, and also reimburse them for home delivery of medication, so that those who are most vulnerable, who are going to opioid treatment programs and receiving methadone, can really are ensured that they have access to care. So that was our focus, has been our focus, particularly with telehealth during the COVID-19 emergency. In one of our campaigns in the fall, we were able to reach 175,000 individuals, among whom there was a 24% open rate and a 21% click rate. And I hear that's like quite good. And digging a little deeper, there were 37,000 unique clicks on some of our links, actually to the provider one that you see there, which we're really excited to see. So providers were really hungry for information about policies and telehealth, and I think that made a tremendous difference. Next slide, please. So what did that mean for us? Once we were able to put out these policies, from 0 to 60, not much telehealth at all, to really allowing more and more telehealth, and then working closely with our providers to get the word out, to ensure then that, hey, this wasn't not only is this in a memo, we've published it and it's out there and the codes are open, but this is real. This is something we want to encourage you to engage in, so that we can ensure access to care for our members. And so, similar to Oklahoma and Maine, we saw a tremendous rise in our telehealth claims. And so you see 6 months before COVID and really 6 months after, for which we have reliable claims. And we saw basically that the numbers went from about 6,000 telehealth visits in a given month to 900,000, over 900,000 visits in a month. So, 1,500% or 15 times fold increase in telehealth visits during COVID-19. And that has really sustained itself, at least until September. And we're looking at and getting more and more data to see how that is evolving. In terms of the services, the top 3 services, and I bet it's not so different from what happened in Oklahoma and Maine. Our top 3 services were, actually many of them were around behavioral health. And so outpatient E&M, psychotherapy and speech language therapy, particularly for children, and even the outpatient E&M was by and large behavioral health and substance use. So we saw that our behavioral health providers were really poised to transition to telehealth and have used and leveraged telehealth to maintain access to care, something that we were really glad to see, particularly as we know that COVID-19 has presented tremendous stress, psychological stress, financial stress, health stress on some of our most vulnerable members. So very glad to see that. Much more work to do. I do want to make a note here. I didn't include it in the slides, but I mentioned that in May, we opened up remote patient monitoring for COVID-19, again, new for Virginia, and interprofessional consultations, including e-consults. The numbers, at least until September, right? So over a 4 or 5 month period, are really small. So RPM, you can count them on one hand, the number of folks who use it for COVID-19. For the interprofessional consultation, it's less than 100. And so I bring that up to say that, there will be some services that are easier to transition to than others. Remote patient monitoring, even e-consults, it requires a level of investment by providers. Yes, it can be extraordinarily useful, but it takes time. It's not as easy to flip overnight, like maybe audio-visual or audio-only synchronous telehealth was and has been. Next slide, please. And so I wanted to, there's a lot of data. We're still trying to understand, how telehealth has been rolled out. Now we're trying to understand what the quality of services has looked like. But one of the first things we looked at was, acknowledging that, in Virginia and around the country, we have a really, poor and fraught and disastrous history when it comes to racial and ethnic minorities and vulnerable populations. So we wanted to see how telehealth was being rolled out among our African-American population. What we found surprised us, but also gave us a little bit of hope. We found that, prior to the COVID-19 emergency, when we just had 6,000 claims, about 22% were among African-American members. African-American members actually shifted, and the uptake of telehealth was more rapid in comparison to our white and other members, accounting for initially 22% to 30% of all telehealth. And so we were really pleased to see that. In terms of the why and how, we're still digging into the why and how. I do want to make one point, which is because, access and equitable access has been such an important principle for us. We moved quickly, we simplified documentation and billing, we opened up codes, we engaged with providers and members, and we also allowed for audio only. And so that's a question that we're asking ourselves now, which is when we think about audio only services, what does that mean for access? And how do we both preserve access, right, equitable access, while balancing concerns around quality in particular? So it's a question we're wrestling with, and one we're taking very seriously, because in speaking with providers, they have said, and our FQHCs, a lot of our primary care clinics have thanked us. I don't always get nice emails, but when I do, I like those nice emails, and have thanked us for opening up audio-only services because it's been so meaningful for ensuring access to their patients. But in addition to that, our other partners have stepped up. Our managed care organizations, through civil monetary money penalty funds for long-term care facilities, those entities have actually provided smartphones and data and minutes and iPads to our vulnerable members so they can engage in audiovisual telemedicine. So I say that to say that this is one piece of the puzzle, the policy, and then there's a lot of work to be done around the infrastructure. And again, I heard that and I saw that in the questions. Next slide, please. And I just have one more slide after this. And so eager to get to the questions. And so what have we learned? So we've learned a number of things, and we're still learning. So the first is that telehealth and certain aspects of telehealth can be rapidly scaled overnight. Certainly we had the impetus of COVID-19, right? That'll do it, right? That'll sort of bring people to the table and really transform care overnight. I think a key question for us is, how do we maintain that momentum? And again, that's something that we're asking ourselves. Providers, patients, payers, we have a new understanding of the possibilities and limitations. I've learned so much over the past, really year, less than that, around telehealth and what it means when we roll it out. It certainly means access to care. What it means for quality, what it means for sustainability over the long term, harder to say. Providers are anxious about whether telehealth authorities will be made permanent. That is one of the most common questions that I get, that my colleagues get. We're in our legislative session today, and that is something that our legislators are debating. Patients do not always have reliable access to broadband. And I think this is why audio only is so important as a modality, and a question, again, that we really need to wrestle with. There's a question around broadband, so we need to wrestle with as a state, as a society, around what broadband access means, not just for virtual care, but also for education. And so it is really, when we talk about structural drivers of poor health, lack of access to broadband is one of them. And so it is important, and it clearly impacts access to telemedicine as well. And so just kind of 2 points I want to make about this. Nationwide, about 20% of Medicaid members live in households without reliable access to broadband. So that's one statistic that's important for us to keep in mind. And then the second is what's happening in Virginia, which is our governor has committed about, I believe it's $35 million to broadband projects. And I know the current federal administration is also very interested in this topic. So it's certainly more to come. The last lesson, and probably the most important, is that we all need to collaborate. We did this, and I heard from Maine and Oklahoma, and I know the other sister states, and many of you probably have collaborated in really remarkable ways during COVID-19 to understand and really improve and march along telehealth together. And we've learned a lot, but we have a lot more to learn. My colleague from Maine mentioned about evidence and how much we don't have and really want to have. And so I think that's some of the work that we'll need to do, and it will take time and humility. Next and last slide. And so for us in Virginia, just to answer the question, what are we thinking about? What does that actually mean? And here's a little bit of a start at, in Virginia Medicaid, how we're thinking about our goals over the longer term, past the public health emergency, and some of our key operating principles, right? And this has evolved over time and will continue to evolve. So our goals are really increasing and sustaining equitable access for our members while maintaining and improving quality through coverage and evaluation. So it's not enough for us to think about equitable access. We also have to think about quality. And we also have to think about, there's telemedicine, right? And is it comparable to in-person? And then there's care for the 21st century and how care can be virtual enabled. So it actually could be better than in-person care. And I am happy to talk more about that. And so how can we not only maintain quality, but potentially improve it? The second is increasing and sustaining providers' willingness to offer services delivered via telehealth by establishing appropriate incentives and certainty. And my colleague from Oklahoma, I think, made a really nice point on this, which is if it's really challenging, and it is, I saw this in my own clinic, the challenges of shifting our workflows to provide telehealth, the extra time it took to really get folks on audiovisual telemedicine, and the hiccups that, the bumps along the road. So for us to sustain it, even in my own clinic, there need to be appropriate incentives and certainty over the longer term. And so I think acknowledging that extra investment upfront in remote patient monitoring, in e-consults, in even audiovisual telemedicine is essential if we want to maintain, continue, and really accelerate the momentum behind telemedicine and telehealth beyond the public health emergency. Some of our key operating principles, we think of telehealth as a modality governed by a lot of the same requirements and parameters as services delivered in person. This is important when we think about program integrity, when we think about quality, when we think about cost even. Existing policy tools, resources should be leveraged. We have a lot of tools now that we have built within our systems. Again, quality and program integrity, same things, right? We can leverage these things today. Policy development, there will be uncertainty. People will want answers. There will not be definitive answers. And that's why we need to march along together. And I have learned that in spades over the past few months, and I know that I will continue to be reminded of that lesson. The last 2 points, robust monitoring and evaluation is critical. And so one of the things we're focused on now is what does good look like when we talk about telehealth? And how do we make sure that our coding schema, how we're providing guidance, allows us to then 6 months or a year from now, we have more answers than we do today. The questions we're asking today, we have some answers for potentially in a year. That's the type of work we're doing now in Virginia Medicaid. And the last is simplicity is paramount. When I think about all of the various decisions that we're making and that come to us around telehealth, right? And again, we went from 0 to 60 in about a week, and we're continuing to refine now. At the end of the day, the more details, the more nuances we put around each service, the less likely it is that it will be successful and taken up. And so we really have to think about the member perspective. We have to think about the provider perspective as we're designing these policies. And so we're paying close attention in Virginia Medicaid to what is Medicare coming out with? What are our commercial payers coming out with? And how can we align as simply as possible so that we are, rather than directing the future of telemedicine, we're really supporting it as much as possible. And so those are some of the pieces we're looking at with those goals in mind. So with that, I'll stop and happy to take any and all questions. Thank you so much.
Big thanks to Dr. Bacciaretti for that very informative and very insightful presentation on Virginia DMAS's approach to telehealth. So right now we're going to open the floor again for question and answer. I do want to again recommend strongly that you use the question and answer function. That really helps us streamline our questions. So first question is about your telehealth champions that you mentioned. Who do you consider to be the telehealth champions? Was that an actual program, or was it just sort of like a campaign that you did? And who do you consider to be those champions?
Yeah, no, that's great. That's great. And part of me is wondering if it's somebody from Virginia who wants to be a telemedicine champion. And so if you are, we'd love for you to join. And so the way it came about was really fortunate early on in our response. Actually, our public health colleagues were coordinating the COVID-19 response with health systems. And in doing so, we raised our hand, myself and Dr. Ruban, who I think many of you know, and said, hey, can we have a committee really focused on virtual care and the role of virtual care? And so she chaired that. I was a member of that committee. And at each of those meetings, which were happening on a weekly basis early on, we had health system representatives coming in and really asking questions and providing real-time feedback. I was able to get, like I said, we put up the policy in a week. And so we were able to get feedback even during that time and throughout around telemedicine. That's why we put up remote patient monitoring and interprofessional consultations. And so they became some of our telemedicine champions. So that formed, we were lucky, that formed organically. And people through that, actually, you'll see some of the stars in our video on YouTube, some of those same folks. So that came about organically, and we had a lot of wonderful partners along the way. And I'll give a shout out as well to Matrix, which is the Mid-Atlantic Telehealth Resource Center, which has also been a really amazing champion within the state of Virginia.
Awesome. Yeah, and thanks for the plug for Matrix, which is one of our consortiums. So this one's actually from me as a moderator. I actually want to ask this question because I'm dying to know. I actually used to also do some behavioral economics work. So I'm curious, I see that that's part of your background at UPenn, and I'm wondering if Virginia DMAS looked into maybe engaging beneficiaries by injecting a little bit of behavioral science into strategies around how to engage them with a telehealth or communicating policy changes and choices and things like that.
Yeah, great. Thanks for that question, Sam. Moderators' rights. So I like that. And so in terms of the way I think behavioral science, behavioral economics really comes into this, one of my favorite, aspects of it is really there's an acronym called EAST, easy, attractive, and I'm forgetting the S, of course, easy, attractive, simple, and timely. And that's a very simple acronym we can all remember and apply to some of our policies. And the way we're really trying to apply behavioral science and really, I'd say human-centered design as well to our policies is really in two ways. One is make it as simple as possible when we're communicating, when we're designing our policies, because that will impact adoption. The second is really taking on the perspective of the provider and the patient. And so I say that, so here's an example. So for providers, I know I'm a provider, I've seen this, and in talking to other providers, that it takes a tremendous amount of time, attention, and dollars to actually set up a really robust telehealth program. And for me, I also know that not only do I want to see telehealth be as good as in person, I want to see virtual care really enhance the entire experience and really bring us to the 21st century. And so with that in mind, if those are the goals, then it's incumbent upon us to actually put dollars behind that. And so some of the policies we're designing, telemedicine, if you look at it in a vacuum, the marginal cost might be lower than in-person care. But for us in Virginia, one of the things we're looking to is at least maintaining that payment parity, at least over the midterm, so that providers can really invest in telemedicine and be incentivized to really invest in that infrastructure so that they can continue telemedicine to the future.
Awesome. Great. And we do have time for just one more question for Virginia, and then we're going to invite all of our panelists to come back on board, and then we're going to open the floor for a panel-wide Q&A. This last question is a little bit of speculation, and I know you talked a little bit about this, but we just want to remind, because some folks keep asking, if you could look into your crystal ball, could you name 2 items you think will continue to be covered after the public health emergency is lifted? And what 2 services or codes or 2 features of the policy do you think are most likely to not be continued to be covered?
Wow, great question. I'm looking into my crystal ball, and I think audiovisual telemedicine will be covered, particularly for outpatient E&M visits. That feels very clear to me. It'll also be covered for behavioral health and substance use disorders. When we think about where the evidence is around telemedicine that we have today, it's really around behavioral health. And we also know that we're in a crisis, an addiction crisis. So those feel like the services that will stay, particularly with audiovisual telemedicine. The ones that will be, the second part was the ones that may not stay, is that right? So I actually think audio only services may not stay. And, I've sort of mentioned that I think it should stay because of its role in providing access. And I don't think it will stay everywhere. So I think different states will make different decisions because of this idea, kind of 2 ideas. One is that it's of lower quality, right? And then the other is this idea that it may inadvertently, because it's lower quality, because it's easier than audiovisual telemedicine, there may be a shift towards audio only that people don't want. And I think a way around that is perhaps by reimbursing audio only at a slightly lower rate. So yes, you maintain quality, but there's a lower rate. And that, of course, introduces other challenges. But I think that in particular, I'm not sure if that will be as widespread.
All right. Great. Thank you, Dr. Bacciaretti, for those awesome questions. We're going to open it back up to all of our lovely speakers. And the way we'll do this is just do popcorn. If you feel like you are best suited to answer the question, we can just start going down the line, and feel free to just jump on. First question is, I'll just throw that question to everybody. In your state, can you think of, we'll just stick to 1 or 2, you get to choose. Can you think of 1, maybe 2 codes or services that you think you can expect to stay in the Medicaid program in your state, and maybe 1 or 2 that you expect that might go away?
I can start. So this is going to sound unoriginal, but it's true. So I'm going to echo my Virginia colleagues' comments, and we will be continuing the evaluation and management codes that we have started offering during this pandemic, and we will also continue to cover pharmacy that we have started offering as well. And similarly, I'm not sure what the path is on audio only going forward. I think that we will want to see what the evidence shows. So that's my unoriginal echo, but that's the case for Maine as well.
Trailer?
Yeah, if I had to predict, looking into the crystal ball, I would probably guess that some of the telephonic evaluation and management codes may go away, and just use those face-to-face moving forward. I definitely see most, if not all, of our behavioral health codes staying open, and maybe even expanding use of that into our inpatient or adolescent inpatient psych facilities. We've seen a lot of actual success with getting more family visits prior to the pandemic through use of telehealth for those kiddos in an inpatient setting, and also a decrease in acting out behaviors after family visits. So I think we'll look at expanding that as well.
Interesting. And actually, that's a really great segue, because we had a question from somebody who's interested in maybe the intersections between your state's telehealth expansions and some trends around telehealth utilization for youth, adolescents, young adults, individuals under the age of 25, perhaps EPSDT population. Can you all speak a little bit to that, about those populations within your state and maybe the intersections of telehealth after the public health emergency?
So I can say that, again, we put out specific guidance on how we wanted to allow telehealth billing for wellness visits and the process for doing that. And we would like to continue that flexibility post-pandemic as well, especially given the decline that we've all seen in wellness visits during the pandemic, that we want to do what we can to get people back up to speed again post-pandemic. And while a telehealth wellness visit doesn't provide for all the preventive care that children need, we feel that it is part of the solution.
Yeah, this is Chetan. I'm going to kind of take that question, just a slight angle on that question, and sorry if I'm not answering it completely, but I'm really excited for this next phase of telehealth, telemedicine, at least in our state, next phase, to really think about how it can, right now it's been very focused on maintaining access to care. I really want to think about it as expanding access to care, particularly for specialty care. And so, some of the work that we're going to do and have started to do, particularly I mentioned the substance use care, but I can see for, children as well. And there are some nascent efforts around expanding access to child mental health. My colleague from Oklahoma mentioned the challenges of finding a child psychiatrist. That's real, certainly in Virginia and probably most places in the country. And so I see, and I'm very excited about how the advent and the of telemedicine and could really support access in that way.
Trailer, did you have anything to add?
I don't. I was just going to say, I would echo the things that my colleagues mentioned, that we're doing the same things and continuing to evaluate that.
All right, great. And we have time for one more question. So I'm going to ask the big one that's going to help kind of bring everything together. In terms of patients' perspectives on the quality of telehealth, what are your thoughts, and how did you evaluate or consider the patient's perspectives on quality of health? For example, do you think patients consider cost savings of time and transportation in evaluating how telehealth is impacting for them? Dr. Bacciaretti talked a little bit about that in terms of the behavioral science aspect of it, but did you inject a little bit of that consideration and framework when you were developing policies, and will you do that moving forward?
So I will say, as I mentioned, we continue to survey our members as far as satisfaction for telehealth goes. But I'm also very involved. We have a member advisory task force that is comprised solely of members that advise us on our policy making. And one of the biggest things I hear from them consistently is a non-emergency transportation benefit, and how it's not the easiest thing to access. And especially if you have multiple children in your family and they don't necessarily they won't accept your entire family as you go to appointments. So we're really seeing a lot of individuals saying this is a great resource for them, and not having to use non-emergency transportation or other barriers in getting to care. And they have access to the technology. So we definitely see a satisfaction level there.
I'll just say a word quickly. So I love what you guys are doing in Oklahoma, and in Virginia, we also have a member advisory committee, and the opinions vary quite a bit. And I've seen it very, this is a gross overgeneralization, very broad, but it really depends on age in some cases, and how used people are going to the doctor. And so for folks who are newer, they tend to like it. For folks who aren't, who they may sort of prefer in-person visits. But I think the overarching theme, if I had to pick one, is that there will be a steep learning curve for patients and providers. So I bet you a year from now, providers will be better at telehealth. And a year from now, patients will also, and members will also have a better sense of their own preferences and how they might want to access telemedicine. So that's what I'm looking forward to, is really learning with our patients and our providers.
I'll just add that the reason why we decided to do the outreach campaign that Sarah shared with everybody is because some of our providers and providers across the board, but even more specifically behavioral health providers, had asked us, they said, hey, you know, we're finding that a fair amount of our members aren't very comfortable with the idea of telehealth and aren't sure if it's really appropriate or what it means. And so the providers asked us, can you help us in getting the word out to try to make this a more normal thing to consider, right? And so that was the driver behind our efforts there.
Very great. And thanks again to all of our panelists for a lively and engaging Q&A throughout the day. At this time, I'm going to hand it back over to May to close us out.
Thank you, Samuel. Just one moment here. So I want to thank our panelists again for the wonderful presentations that they have done today. We learned a lot, and it was very interesting to see, you know, the commonalities, but also the diversity of what you guys did in your approaches towards COVID-19 and telehealth policy. I just want to remind folks that the recording will be available about 48 hours after this webinar ends. Please also know that you can subscribe to CCHP's newsletter to find out more about upcoming events and information around telehealth. Those are the links in which you can access all that information. I do want to let you know that the final webinar will take place next week for our winter series. We are going to be looking at a roadmap for Medicaid telehealth policy beyond the pandemic. We'll be hearing again from various states, but we'll also be hearing from MACPAC, which is the agency that looks at Medicaid programs specifically for the federal government. Once again, thank you to our speakers. Thank you to the CCHP staff. Know that if you attended this webinar, you will be getting an evaluation. So I ask that you do fill that out if you can. That really helps us understand what you may be interested in for future webinars. We will be doing a spring series. So if you do have topic ideas, or if your Medicaid program has a speaker who would like to speak to one of these webinars, please let us know as well. So thank you, everyone. Once again, thank you to our speakers. Have a great day.